Good morning. I'm going to present the data from VALOR, which is a multinational randomized phase 3 double-blind trial of patients with refractory or first relapse AML. Before I show the study data, I'd like to put this slide up. This is very exciting times for physicians who work in hematological cancers. There's been many approvals in a variety of hematological malignancies, and the patients are really clearly getting the benefit of these approvals. Unfortunately, our patients with AML to date haven't had so much of this benefit. The last approval was in 2000, and with the voluntary withdrawal of that drug, there hasn't been any recent approvals. And as you heard from Dr. Stein, this is hopefully going to be changed because we are having a lot of new exciting drugs in development. Now, Vosaroxin is a first-in-class anti-cancer Quinolone derivative. It's a drug that has been evaluated in preclinical studies in AML cell lines and patient samples, and has shown to be effective and has shown to be synergistic with Cytarabine. It does have a few characteristics that make it particularly interesting. That is, it is not a P-glycoprotein substrate, and its activity is independent of the P53 mechanism, and it has limited reactive oxygen species formation, which differentiated it from anthracyclines in terms of reduced potential for cardiotoxicity. So VALOR was a phase 3 randomized double-blind placebo-controlled trial. The patients were randomized on a one-to-one basis. They did get stratification based on age above and below 60, duration of first remission, and whether they were treated in a US or non-US center. The two regimens were Cytarabine at a dose of 1 grams per meter squared daily for 5 days, plus Vosaroxin at 90 milligrams per meter squared on days 1 and 4, and this was based on a previous phase 2 study that was recently published by Jeff Lancet, and the control arm was Cytarabine alone. And patients could get 1 or 2 induction cycles, and those in remission would get 1 or 2 consolidation cycles. The primary endpoint of the study was overall survival, with a number of secondary and tertiary endpoints that you see here on this slide. I'd like to go over the eligibility criteria because it's important, because I think the design of this study was very well thought of, and the patients were homogenized as much as possible. So they could go on the study if they were refractory. That means they didn't achieve a remission to their induction therapy, or had a short duration of first induction, which was less than 90 days. Patients could go on the study also if they were first relapse, and they were categorized as early first relapse with the CR1 duration of 90 days to 1 year, or late first relapse with a CR1 duration of 1 to 2 years. Now, importantly, all these patients had to have received at least 1 cycle of Cytarabine and anthracycline-based induction therapy, and also importantly, they could not go on the study if they had received more than 5 grams per meter squared of Cytarabine within 90 days of randomization, or had undergone an allogeneic or autologous transplant within 90 days of randomization. This is the primary endpoint of the study, which is overall survival. You can see the overall population enrolled on the study was 711. This is one of the largest studies in AML, and probably the largest study in relapsed AML. As you can see, the median survival for the Vosaroxin and Cytarabine arm was 6.7 months versus 5.3 months for the control arm, with a p-value of 0.06. Now, using a stratified log-rank analysis, which is a very commonly used analysis and is actually the analysis that's used for most of the solid tumor trials, the p-value was 0.02. Looking at the responses, the patients who were on the Vosaroxin and Cytarabine arm had a 30% overall CR rate, as opposed to about 16% for the control arm. And if you look at this among all the stratifications, this was superior for the Vosaroxin arm in all of them, with perhaps the exception of patients under the 60, where the difference was not as great. And if you look at all the responses, again, the advantage was clearly superior for the Vosaroxin arm of the study. Now, a large proportion of patients underwent an allogeneic stem cell transplant, overall about 30%, and if you divide it by age, patients over the age of 60, there was a 20% transplant rate, after after completing therapy, versus for the patients younger than 60, about 45%. And that's actually a very high transplant rate in a relapse setting. And when you censor the data by allogeneic stem cell transplant, you can see that, again, there's a statistically significant advantage for Vosaroxin and Cytarabine arm with a p-value of 0.02. If you look at the various strata that were included in the study, patients above and below 60, you can see that there is a clear advantage for the patients over 60 with a p-value of 0.06. And I would like to emphasize the point that this population, patients over the age of 60, accounted for 2/3 of the patients randomized on the study, 451 patients, which clearly is a very large study on its own. Among the patients younger than 60, there was no advantage for the Vosaroxin arm. And again, if you look at the first CR duration stratification, the clear advantage was seen in the early relapse population. That's those whose first remission was more than 90 days and less than 1 year. What about toxicity and mortality? There was a higher incidence of toxicity in the Vosaroxin arm, but we were pleased to see that this was essentially all related to myelosuppression, and there was no difference in the two arms of the study in terms of organ toxicity. And more importantly, the increased toxicity seen on the Vosaroxin arm did not translate to any increase in mortality, with both 30-day and 60-day mortality being equivalent in the two arms of the study. So in summary, the combination of Vosaroxin and Cytarabine is associated with a survival advantage as compared to Cytarabine alone, a higher CR rate with a very strong p-value, and no difference in 30-day or 60-day mortality. So this is, again, one of the largest studies or randomized studies in the relapse and refractory AML setting. There was a clear improvement in overall survival, particularly for the patients over the age of 60, and there was a high transplant, post-treatment transplant rate, and this could obviously underestimate any benefit for the Vosaroxin arm because of the high transplant rate. And in my opinion, this data support the use of this combination as a new standard for salvage therapy in older patients with AML.